And there is a huge overlap. In spine, especially orthopedics. Orthopedics tend to operate a lot on the spine, much more than neurosurgeons. Why? Because of money, income, and good outcome. Neurosurgeons in general do not like the spine a lot because of the interest of the brain mainly. Plastic surgery with peripheral nerves. Actually, most of the peripheral nerve disorders and tumors are operated by plastic surgeon, not a neurosurgeon. I know only 2 or 3 neurosurgeons in the whole kingdom who subspecialize in peripheral nerves. Head and neck, it was the ENT, and ENT is the closest friend to us, not a neurologist, but ENT. Why? Because of skull-based tumors, extend from the neck upward or from up downward. So, this is a question. I want to ask somebody here, who's interested in neurosurgery? Again, raise your hands. Why? Why you want neurosurgery? Yeah, your reasons.
Because I think it's such a complex organ, and it's something that I would want to devote my entire field of study on.
Complex. This is very good answer. Complexity is part of our interest. Who's else interested? With a pink, yes.
Brain or challenging?
Challenging.
It's the brain.
It's definitely challenging. Okay. What else? Who's else interested? And why? The hands suddenly. Okay. So obviously, this is sine group, right? So most of you are interested in neuroscience. So I'm assuming partially interested in neurosurgery. So the main thing is not the brain or the central nervous system or the neuroscience. The main thing in neurosurgery, you want to do surgeries. You want to operate. So if your second interest is in general specialties, surgical specialties, regardless if it's general surgery, orthopedics, or anything, you are on the right track. People do not recognize this. They think that neurosurgery is something, okay, CNS is part of it, but the majority of the things are actually surgical. So the first question you should answer, do I want surgery or not? And this surgery, regardless of that subspecialty you are interested in. So it's surgery always, and you hate the OR, just escape from neurosurgery. And there's a huge difference, I'll talk about it, anatomy approaches, delicate surgery, obviously. I have to go fast with the presentation. Highly technical operating theater, this is very nice. When you go to the neuro room, you'll find intraoperative MRI, you'll find the neuro navigation, so you can locate where is the tumor or the pathology. You'll have a neurophysiology that monitor the neurological function. If the patient's status, you cannot examine him. Or you can awake him and do with surgery and live examination while doing surgeries. Life-saving, obviously, because if you operate, for example, plastic surgery doing cosmetics, some people find it not rewarding, psychologically rewarding. But when you save a person's life, this is something people are interested in. Multidisciplinary teams, always. We have now in KFMC about 4 meetings per week. Pituitary, tumor, vascular, and one more, I don't remember. All multidisciplinary meetings all the time. And depth rather than width. What does that mean? When you go to other subspecialties, ER for example, their knowledge tends to go in width. They want to know everything, about everything. But they are not experts. They're not experts in a certain field or system. Neurosurgery, no. Once you grow, your vision will get narrower and you'll get more depth in knowledge and skills. So if you are interested in depth, focused depth, neurosurgery is good for you. So how to choose a specialty? So I myself had a lot to choose neurosurgery. Actually, I didn't know what's neurosurgery in medical school. I remember subdural hematoma, epidural hematoma, that's it. I never went to our neurosurgery in medical school, partially in internship. So you make a plan, schedule, you put never, specialties that I'm not interested in, this is my real schedule, my real table. And you put subspecialties that you are actually interested in deeply, and some subspecialties are actually indifferent. And you start examining the one you are interested in. How to do that? First you decide, you want surgery or medicine? This is the first question you want to answer. And if you're able to answer this question, I assure you will go to the right subspecialty that you are interested in. You read about specialties in the books. There are certain books you can read about. Websites, YouTube, you can see interviews, workshops like this. You can ask, but be careful because neurosurgeons tend to exaggerate their subspecialty. they'll tell you all the bad stuff, but will not tell you the good stuff. To show you how they work. They work so hard, they tend to show that. But this is, so be careful when you ask neurosurgeons, especially junior residents. They exaggerate a lot about their subspecialty. And the most important thing to take electives. Just go there, see how the people operate, see the environment. This is the most objective way to know if you are interested in or not. One of the interns today asked her, are you interested in neurosurgery? Just part of the question. She said no. I said, are you sure? She said no, I want to join neurosurgery, never. And she's interned for 1 month. I think this is a successful month because she ruled out one of the subspecialties that she was interested in. And if she joined that later without proper elective, she may get into a real trouble. So, this is neurosurgery, which neurology is totally different thing. So, for example, let's see this MRI. You can see here is the pituitary, and there's a huge tumor. This is the neural pituitary. There is a huge tumor compressing the optic chiasm above and eroding into the left ventricle. If you ask a neurologist how to read this, he would try to formulate a differential diagnosis instantly. This could be this, that. They are focusing on diagnosis because their treatment options is actually limited, very limited. But when you ask about the neurosurgeon what do you think about this image, he'll start thinking, how can I remove it? So we study the anatomy. Okay, there is internal carotid artery here. I cannot go there from this approach because I will endanger it. I can go up, opening the corpus callosum ventricle, the lateral ventricle, but then I'll end up with the fornix here and the optic chiasm in my way. I'll start working between the optic nerves. I may injure them actually. Or I can go through the nose, open the sphenoid sinus, for example, and remove the tumor. So it's all anatomy, pathways. You just want to try to examine your pathways to reach a lesion. This is an example how I can tell you to reach certain areas in the ventricle, for example. You see the patient positioning, how the head tilted, how I can approach this area in a proper way, how I retract in certain lobes without injuring them. So mentality-wise, neurology is totally different than neurosurgery. That's why I said to choose both now. You should evaluate yourselves what is the proper subspecialty. So when neurosurgery is not good for you, you're planning to relax after training, obviously, because this is surgical specialties. And surgical specialties, surgeons improve with volume. The more they operate, the more they get better. So trying to relax later will be a dangerous surgeon because it will cause harm to the patient. So always, actually the peak for neurosurgeon in their 40s, 50s. This is the most time they work a lot. They spend hours in the hospital. So future plan should be a lot of surgeries, even when you get old and you have family. Just to be called a neurosurgeon, it's like an ego called neurosurgeon. In the hospital, all subspecialties are the same. No one will see, look, who's a neurosurgeon, he's a good neurosurgeon. No one will look at that. Actually, a good internist is much better respected than a bad neurosurgeon in any medical place. We don't like the war or wounds. One of my friends is an intern, and he decided to choose surgery for residency. At the end of the internship, he said, I don't want. I cannot see wounds. Blood and wounds and this trauma, I cannot tolerate this. So I'm not, he just erased the neurosurgery totally from his options. Payments and lifestyles, your highest priorities. There is a good payment in neurosurgery, but it's not the highest priority. Other subspecialties have much higher priorities in terms of income and economic status. Questioning your choice. You should be neurosurgery 1, 2, 3, 4, 5, always. If you are questioning your subspecialties, it's better to examine your interest again. Not interested in science, obviously, and you are lazy, also obviously. So, this is an example of how a good program, how can a program train your surgeon better than other programs. So if you want to choose a program, especially most of you will be not Saudis and you cannot join the Saudi program, we are interested in programs outside. And you can see here professional-based training. You should be trained and operate under supervision. So the consultant or the attending is supervising you and teaching you when you start doing your skills. So if you make a mistake, you can correct it. You don't become a consultant doing the same mistake again and again and harm the patient. As you can see here, there is high volume of patients for this one, for example, but he's not progressing. But you can see another surgeons who have lower patients per year, but they are progressing in terms of quality and skills. So how is the practice? You operate on the brain once, you operate on the spine 10 times. So the ratio is 1 to 10. As you can ask yourselves, one who's from your relatives has a spine issue. I think almost all of you. But who has a brain issue? It's very rare. So brain lesions and brain pathologies are actually very rare in comparison to other systems. Practice is subspecialty and hospital dependent. This is very important because if you work in a secondary hospital, you're not operating on tertiary cases. Why? Because they don't refer it to you. So you end up doing trauma. You can do some tertiary cases occasionally, but you'll not, you may harm the patient. Why I'm saying this? Because you have limited cases per year. You have to do these cases to be able to do a certain case safely. For example, clipping aneurysm, you have to do 20 to 25 reefs per year. If you are unable to do that, then the license will be taken from you. Lifestyle is variable. It's a stressful lifestyle neurosurgery, definitely. I think all of you know that. But still, you can custom your practice the way you like it. After you finishing residency is horrible. Absolutely horrible, I'm telling you. Family life is also variable. I think we can have a good family life with a neurosurgery still. Income, as I said, with the spine as always. So that's why orthopedics are smart. We operate on the spine to get money. But once they reach the spinal cord pathologies, the nervous system, they stop. Here's a neurosurgery comes in, and these surgeries are does not have high income and has worse prognosis. So neurosurgeon operate with the worst pathologies in the spine. As I said, tertiary reference center positions. In Riyadh, actually, most of tertiary centers are full. So better to go to other places or there's a referral center and consider other subspecialties. So you may find certain subspecialties are full and others are still, there is still need for it. Females, definitely females can neurosurgery. So there's some misconceptions about outcome. My first internship, my first neurosurgery rotation was in Shimesi, and Shimesi was a trauma center. So I went there. I know. Someone told me that neurosurgery has a bad outcome, but I went there and found all the patients comatose with a tracheostomy and NG tube. They cannot talk to you. They are comatose, and all of them like this. I said, what the hell is this? They told me neurosurgery is bad, but not like that. I spent 1 week just rounding up the patient, writing a few notes, and going to the next patient, and totally not talking to anybody. When I went to other centers, I found the exact opposite. Patients come with a huge brain tumor, some minimal deficit, maybe numbness or some sensation loss. They do the surgery, which is 12-hour surgery, and they walk outside from the hospital. Why? Because of the trauma. Trauma has a very bad outcome because there is already a brain damage. So when you go to trauma center, you have this misconception that it is because of neurosurgery is bad. No, because the pathology of trauma is bad. So bad outcome is totally rubbish. It's wrong. Neurosurgery has a good outcome. As I said, most patients will die of paralysis after surgery. This is a true risk, but it doesn't necessarily happen in every surgery. Surgery are super long. This true is skull-based. Skull-based, you must spend 36 hours in surgery, actually. We have one case next week, planning for 48 hours. Skull-based case, skull-based tumor. No place for females, obviously. Awful lifestyle. It's not awful, it's bad. It's not awful. But you can custom it the way you like. High burnout rate. I think other specialties have more burnout rate than neurosurgery. Less reading than medical specialties. This is a profound mistake. Less reading than specialties. In neurosurgery, if you read just the surgical anatomy, will understand what I mean. It's so complicated that I spend hours to just understand a single paragraph. And the reading is active. In medical specialties, the reading is linear. You just bring a book, you just try to memorize the stuff. And you know you have to understand the anatomy. So you have to have cadavers, you have to open YouTube, you have to see pictures, you have to just rotate your book everywhere just to understand the 3D anatomy. This thing you're going to see in the OR. I have a tumor, I can't join your surgery. If the tumor is physiological but exaggerated, this is normal. With time it gets better. You can join your surgery, definitely. But it's pathological, like Parkinson. This is a progressive disease, as you all know. You cannot join it.
Do I have essential cover?
This is a good question, and I've asked somebody, and there is one consultant in Canada, he's a pediatric surgeon. I think his name Sinclair, I don't remember. He has essential training. When you see him under the microscope, it's like everything is shaky. But when he starts to move, his movement is so smooth that he do the most delicate procedures. So to answer the question, no, I don't think essential tumor I think essential tumor patients can join neurosurgery, definitely, but we have to train more. This is the intraoperative MRI in KFMC, as you can see. This is King Faisal. Okay, so I'll go this fast because most of you are thinking about Saudis here, so you cannot join the Saudi program, or it's difficult to join. So our program is 6 years in total, multiple cities, variable acceptance rate, and 54 residents in this year, 15 of them are females. Training quality is good. You have secure time for teaching and extensive hands-on training. And hands training goes up with your level. The more senior you become, the more chance you are given in the OR. This is an example of our schedule for teaching. So about the hands-on training. As you can see from the start, you start cutting. From my R1, you have to go to the OR, you start cutting. The more you progress, the more you do certain complex things. More electives, skull base, aneurysm, advanced spine, so it depends. R6, usually most of them, they start to prepare for the exam. In the first 6 months, they do surgeries, and then they start to prepare for the exam. The point of this program is to make you independent. So when you finish the program, you do surgeries alone. But you realize that you cannot be independent. Still, you need supervision, especially in vascular cases, because they are very risky. So what is the misconception? There is no hands-on training. I don't think so. I asked certain consultants who came from outside, what do you think about the Saudi program? They said it's within the range. So if in Canada or the States, there's a program that's better and there's a program that's worse. So it's within the average in terms of hands-on training. And in terms of research, it's very bad. And anybody, if you're interested in research, will be recognized like this. Because nobody do research in surgery. Actually, the whole surgical literature is garbage. The whole surgical literature is full of bias, full of. In your surgery, you have like one or two level 1 evidence as guidelines. Most of the evidence available is based on retrospective studies, which is bad in retrospective studies. So, if anybody interested in research here in Saudi Arabia, you will scared. Okay, centers in Riyadh, King Faisal, King Fahad, King Abdulaziz, National Guard, King Saud, King Khalid, and Prince Sultan. It's a joint program, so we rotate in all the centers. The more senior you become, the more you have the chance to select which center. So how about outside Riyadh? There is certain centers also, but in terms of hands-on training, Riyadh is the best. Okay, so should I stay here or go outside? Huh? If you are concerned about the skills and being a safe surgeon, you can stay here, if you can. But if you want to go outside, Canada was the preferred option. Unfortunately, it's not preferred anymore. But if you can go to Canada, it's good because the acceptance rate is high. The States, the problem with the States is extremely competitive. Extremely competitive. And all of the residents who try to go there, they failed miserably. They spend 5-6 years trying to get a position and they always fail. So I don't recommend going to the States actually. If you want to take like a PhD, wait to try to build your CV more, you can do that. But when I get this question, should I go to the States, I say no. How about Europe? Europe acceptance in neurosurgery is easy. You can get a position. The problem with the language, especially Germany, the problem with Germany is that there is this handling track. And I know one Saudi went there, one Saudi resident, he left the Saudi program, went to Germany, became R4, he left the program and came back. He said, I'm R4, R5, and I cannot do proper chemotherapy. Chemotherapy is done here by R1s. And this not because the Germans are bad, because this is their mentality. They want you to build your experience after you finish the program. So this will delay your time to become an expert. You'll become an expert eventually, but not like someone who came back from Canada or finished the program here, who can operate independently early. France is another option, also South Korea. Unfortunately, I didn't have a lot of information on it. So I think there's 15 minutes left. I have to go fast. Fellowships, vascular, endovascular, so doing thrombectomies for stroke. This is like a huge thing in neurosurgery. Trying to remove thrombus from stroke patient who came with hemiplegia and started moving his limbs. This is huge. This can be done also through radiology, but endovascular can do both options. It has like a thrombus along with hemorrhage. You can do both. Scalable, for example. Skull-based oncology. Oncology treating only GBMs, glioblastomas. Oncology does not mean removing tumors. All these subspecialties actually remove tumors. Oncology dealing only with research and glioblastomas, trauma, pediatrics. Pediatrics is positions available all over Saudi Arabia. Because Saudis is like mitosis all the time. So pediatric patients available all the time. Functional epilepsy is very limited to only tertiary centers. Minimally invasive endoscopic. Spine also always available. Spine patients a lot, and they get a lot of money, relaxed lifestyle. And peripheral nerves also available. So how about living acceptance? This number, I don't think it's true anymore, because how is Saudi Health Commission changing their conditions and their CV grades and whatever? It's too fast. I cannot go with that. So my point is, just focus on your SMLE exam and your GPA. It's the most important things. The second thing is take electives and get the recommendations. If you did both, you'll get the position. The third thing, do not commit to the flags in electives. Never. The flags mean intense attitude and other stuff. Because this is a total no-no. You can take certain courses internship. I prefer suturing courses like OSA or other courses. ATLS is a good one. There's some neuro courses designed for instance, drilling or basic approaches. These are good courses as well to prepare you for residency. So this is the day resident routine. What we do usually, we run early in the morning. If you are a junior, you go to the wards. For a senior, you go to the ICU. If there is OR, you go to the OR. After you finish the OR, you go out, you go back again and do a closing out. This can be 3 p.m., this can be 11 p.m. So it depends. So this is an example of what we do. Like this patient, for example, came, what we do usually in our practice. This patient was referred to us in the clinic and was told that he has some lesion, pathology, and he has hearing loss on the right side. So what we think is how to remove that. This is tumor, the vestibular schwannoma, they're growing, taking a hearing out. So how we can remove this? A neurologist would say this is a vestibular schwannoma and stop. This multiple sclerosis and stop. Okay, we provide some medical treatment. But we go further. Even the radiologist will just describe the lesion and leave all the normal stuff. We look to the normal stuff, to the normal structures, because we may injure them. So we can go from here, we can go from here, we can go from here, or we can go from here. So this is how we think. So we decided to do what we call the retrosigmoid, just retract the cerebellum, and just go into the tumor and remove it. This is how neurosurgery think. This is what it looks like, actually. So you have multiple cranial nerves all over, 5th, 8th, and 7th behind it, and the lower cranial nerves and control swallowing and control breathing. So it's not simple. And this picture I spent maybe 1 week just to appreciate. Where is the nerves coming from? Where is the surgeon is coming from? Which structure is important to sacrifice, which is not? And this is how the surgeon operates. Again, different view. You see the position of the patient. The problem with this neurosurgery, the surgery, there's multiple steps, and all the steps are risky. For example, we put pins on the head. This pins could slip. You did not start the surgery, just inside the patient, and you put the pin. Could slip and injure him. You could position him wrong, cause a nerve pulses. Break plexus injury or come over a nerve pulse and cause him foot failure. And you did not do anything yet. You did not even do the skin incision. And also you can damage the veins here and cause him venous thrombosis. And you start to recover. The patient after surgery is not waking up because he has a massive infarction and you didn't know that. Some patients you put him in a sitting position. And the air comes in, go up, severe pulmonary embolism or stroke, and the patient dies. And I saw that. I have 12 surgery patient on a pineal tumor, he's trying to wake him up, he's not waking up, he cries and died in front of us. You can injure one of the cranial nerves here. Patients wake up with a facial palsy, you remove the tumor, record the patient, but she will follow you in every hospital because of her facial palsy. She will forget that you cured her. She will come back after you and make a complaint about just facial palsy. You can do extraction, damage the cerebellum. You can injure one of these arteries and destroy her hearing. But this is multiple steps, and all these steps are risky. And in signing, when we bring the patient to OR, when they ask about the complications or risk in the procedure, the consultant says it's all risky. It doesn't mention it. It's always our favorite word. It's all risky. So this is enough. Okay, here's an example. Maybe so as you can see, he's trying to remove the tumor. There is the nerve here, like I think. Actually, you think this is a normal structure. You cut the patient and patient. You don't know that it's actually a nerve because it's very stretched. This is certain resources who's interested in neurosurgery. This is for detailed anatomy. This is concise anatomy. And I recommend this book actually, the one with the pink, because it's help you read emergency CT for both neurology and neurosurgery. And this is the first thing you get asked about in intensive. They put a CT plane, and they ask you to read it. So if you are able to acquire the skills early, it's very good. All right, thank you so much.
Thank you, everyone, for listening. If anyone have any questions to the doctor or in general about neurosurgery, he's welcome to ask. Anyone has any questions?
I'm up to second year this year. First of all, thank you for the amazing talk. I have two questions. First of all, what fellowship are you thinking about? And why?
I'm interested in vascular for one reason. It's very challenging. It's extremely challenging and it's trending, especially in the vascular victims. It's trending and it's very rewarding in terms of treatment. So it's challenging is the question, is the answer.
And what is the most interesting case you saw in your residency?
Always aneurysms, because aneurysms require delicate skills, sharp dissection, scalp-based approaches. So aneurysms are always interesting cases.
Thank you.
My question is, how do you deal with it when a patient dies and you're the one operating?
Fortunately, we are not operating alone yet, we're still residents, but we do have mortalities from surgeries, and blunt, actually, become indifferent. I think this question I can answer and become a consultant and the primary, the most responsible physician about the patient. I think it will mean more than now.
I actually have two questions. First of all, thank you for the talk. My first question is, how do you deal with like the legal issues that can sometimes happen with neurosurgery or any surgery for that?
It's a good question. As long as you're following evidence, you're following guidelines, you are good. As I said, the problem is surgery, there is not a lot of guidelines, but if you want to make a clinical decision, you should justify it properly. Documentation, because with council plans is to decrease the number of residents, as I said, because they work in tertiary centers, and the tertiary centers are limited. Cardiac surgery is worse, because the cardiac centers are even more limited. So that's what I mean. Not now, but in like 10 years in the future. So don't be scared, you all have physicians if you are interested.
What's the relation between the peripheral nerve surgeries and the plastic surgeons?
Plastic surgeons operate on forearms, and they are very expert with nerves anatomy. So they know the structures here. We are not familiar with peripheral nerves, the limbs. We don't operate a lot like the brain or the spine. However, when you go outside, you'll find the neurosurgeons, they do rotate on peripheral nerves, and they do have more knowledge in terms of peripheral nerves anatomy. But as I said, this is an interest. The neurosurgeons in Saudi Arabia, they are not interested in that, so that the subspecialty deviated out of plastic.
One more question. What can you do in medical school to help your chances in matching with your surgery?
Where?
Either here or outside.
Here, as I said, your Saudi Health Commission exam, GPA, and good electives with recommendations. If you have these three things, definitely you get a position. The higher you get marks, the more likely you get a position. Outside, it depends on the city. United States, I said almost never. Canada, I don't know. I don't know what will happen later.
What about research?
Research, I think there's points now in Saudi Health Commission for research, right? If you get these points, you're good to go.
Usually foreign students do tend to do research in fake hospitals as a way of getting accepted into programs, whether it's surgery, whether it's...
Exactly. Yeah, exactly. Questions?
For Germany, you said it's difficult of, there is this hands-on experience?
Yes.
Is it in neurosurgery only or?
Neurosurgery. I'm not sure about the other specialties, but in neurosurgery, Saudi residents, they are not satisfied with the training there. Yes.
You mentioned Greenberg.
Yes.
Where do I find it?
Amazon, or I think it's available. مكتبة شمس. مكتبة شمس. أو تطلبه من أمازون يعني. أو حمله في الآن.